Good day. My name is Michael Klompas. I'd like to speak to you today about ventilator-associated pneumonia. So these are the topics that I'd like to discuss with you today. Let's review together the accuracy of clinical signs to diagnose pneumonia. What kind of imaging should we get? What pathogens are associated with VAP? What should we be treating with? Do we need to get cultures? How long should we treat for? And how can we improve outcomes for ventilated patients? In order to get us in the right frame of mind, here's a case study. A 68-year-old gentleman is admitted to the medical intensive care unit with severe pancreatitis. A large bore catheter is placed for aggressive fluid resuscitation, and a Foley catheter is placed to monitor urine output. His pain is managed with a continuous infusion of opioids. The patient develops progressive hypoxemia. A chest X-ray shows bilateral pulmonary infiltrates, and the patient requires intubation. The patient has daily fevers. On hospital day 4, the patient's nurse thinks he looks a little more drowsy than before and has more secretions. On exam, he opens his eyes to voice but doesn't follow any commands. His temperature is 101.9. His heart rate is fast at 118. His blood pressure is 98/64. His ventilator settings are assist control with a PEEP of 10 centimeters of water and FiO2 of 50%. His JVP is difficult to visualize. There are possibly some crackles in the bases. He has marked abdominal distension and bilateral lower extremity edema. His labs are notable for a white count of 12.2, his hematocrit is 32, his platelet count is 140, sodium 130, creatinine 1.8, LFTs are normal, and his INR is 1.0. Urinalysis has 4 to 6 white blood cells per high power field, and a portable X-ray shows edema, and maybe there's a left lower lobe infiltrate. Here's the X-ray. Take a look for yourself. If we look at this X-ray, we can all agree that it's certainly an abnormal chest X-ray. Let's see. Whoops, oh, sorry. Can I go back to the slide?
Yeah, we can start at the top.
That's what to get the point.
Or you can use the arrows on
I was just noticing that when I use the mouse, there's no arrow shows up on the big screen, which is why I.
Really?
That's what threw me.
All right.
You know what? Nope. Well, there must be a way to do that. Well,
I really don't need it, but.
I think you have to have the mouse
Over this side.
there.
So maybe that's right. Maybe that's the way to do it.
Yeah,
so that's the way to do it.
'cause
Fine. Okay, no, that's great. Thank you.
So, do you want to start from the top?
Yeah, I don't know what the exact cut point was from the.
Because of that signal loss, I'm sorry, could you start from the top, or how far were you in? Or just slide 5 is really where the...
Well, yeah, I'll go back
I mean, we
to.
don't have to.
I'll start on the slide, number 3. These are the topics I'd like to cover today. How accurate are the clinical signs to diagnose pneumonia? What kind of imaging should we get? What pathogens are associated with VAP? What should we treat with? Do we need to get cultures? How long should we treat for? And how can we improve outcomes for ventilated patients? In order to get us in the right frame of mind, here's a case study. A 68-year-old gentleman is admitted to the medical intensive care unit with severe pancreatitis. A large bore catheter is placed for aggressive fluid resuscitation. A Foley catheter is placed to monitor urine output. His pain is managed with a continuous infusion of opioids. The patient develops progressive hypoxemia. A chest X-ray shows bilateral pulmonary infiltrates, and the patient requires intubation. The patient has daily fevers. On hospital day 4, the patient's nurse thinks he looks more drowsy than before and has more secretions. On exam, he opens his eyes to voice but doesn't follow any commands. His temperature is 101.9. His heart rate is 118. His blood pressure is 98/64. His ventilator settings are AC, this is control, with a PEEP of 10 centimeters of water, FiO2 of 50%. His JVP is difficult to visualize. He has possible crackles in the bases and marked abdominal distension. There's bilateral lower extremity edema. His labs are notable for a white blood cell count of 12.2, a hematocrit of 32, a platelet count of 140, a sodium of 130, creatinine of 1.8, LFTs are normal, and an INR of 1.0. A urinalysis shows 4 to 6 white blood cells per high-power field, and a portable X-ray shows edema with perhaps a left lower lobe infiltrate. Here is the chest X-ray of this patient, and as we look together at it, we can certainly see that there's some abnormalities over here. There are opacities in both bases. Now, it's difficult to interpret, so you might want to see the radiologist's read of this film. Here it is. Diffuse patchy airspace disease, right greater than left, with obliteration of both hemidiaphragms. Opacities possibly slightly increased since yesterday, accounting for change in patient position and inspiration. This could represent atelectasis, pneumonia, or effusion. So my question for you as you review this case is, does this patient have pneumonia? So think to yourself where you stand on that spectrum. But the real push comes to chase when you think about the next question is, would you start antibiotics? And I venture to say that the answer to the first question, does a patient have pneumonia, is maybe. Would you start antibiotics? I'm sure that if we would ask 10 people, we'd get 10 different opinions as to what they might do in that case. And so the question is, why is pneumonia so difficult to diagnose? And I think the core lesion is that many medical lesions, many medical conditions in hospitalized patients present the same clinical signs as pneumonia. So if you think about the core clinical signs for pneumonia, radiographic opacities, fever, abnormalities of white blood cell count, impaired oxygenation, increased pulmonary secretions, you will no doubt be able to think to yourself of a large differential diagnosis for each of those different clinical signs. In other words, many things that can go wrong for a patient on a ventilator have a core common clinical presentation, a core common set of clinical signs with which they manifest. When we've analyzed the accuracy of clinical signs to diagnose pneumonia, we have found, in fact, that they don't do a very good job. So here's a review that looked at the accuracy of clinical signs for VAP relative to autopsy, relative to histology. This was a systematic review with 14 studies, involved about 655 patients. The results over here are presented using likelihood ratios. You'll recall that a likelihood ratio tells you how to take your pretest probability of disease, and you take your pretest probability of disease, you multiply by the likelihood ratio for the clinical sign, and that gives you your post-test probability of disease. So if your pretest probability of disease is, say, that you think the patient has a 20% chance of having pneumonia, and you have one of these clinical signs present, if it has a likelihood ratio of 1, that means your post-test probability of disease is going to be exactly the same as your pretest probability of disease. And what we see here is that the likelihood ratios for all the core clinical signs that we look for to diagnose VAP are just about 1. The only possible exception over here is a new infiltrate, and the absence of a new infiltrate has a negative likelihood ratio of 0.3. Now that's not particularly powerful in terms of ruling out disease. We say that for a likelihood ratio to really be helpful, it should be above 5 to 10 or below 0.2 to 0.1. And over here we see it's around 0.3. So it makes a pneumonia less likely, but it's certainly not diagnostic. And in fact, when you examine patients who at first blush look like they might have a pneumonia, they'll find that they have many underlying conditions. So here's data from a couple of studies in which there was intensive analyses of patients who, again, at first blush looked like they had pneumonia, they had fever and infiltrates. But on closer evaluation, those fever and infiltrates could be attributed to ARDS, diffuse alveolar damage, thromboembolic disease, hemorrhage, infarction, fibrosis, carcinoma, lymphoma, contusion. What I think is just pretty interesting from these studies as well is that for a critically ill patient on a ventilator, often there's more than one thing going on at a time. And individually, these things might look nothing like a pneumonia, but when present together, they can give the net clinical picture of a pneumonia. So for example, a patient might have increased secretions from a tracheobronchitis or a fever from a central line-associated bloodstream infection or a urinary tract infection or drug fever. None of those things unto themselves would look to us like a pneumonia, but what if that same patient at the same time had an abnormal chest x-ray because of pulmonary edema or atelectasis or contusion or fibrosis? Collectively, it might look like that patient has a pneumonia. It will not surprise you then that if you look at clinical series assessing the accuracy of clinical diagnosis for a VAP, we're not so good. So here is another histology study. These investigators looked at 253 patients who went on to autopsy, and they applied, first of all, what they call a loose definition for VAP, which was an infiltrate and at least 2 of an abnormal temp, white blood cell count, and purulence. And you can see that the sensitivity for that constellation of clinical signs is around 65%, and the positive predictive value here was around 55%, basically a coin toss. So these investigators took it up a notch, and they also applied a strict definition with an infiltrate in all 3 of abnormal temperature, abnormal white blood cell count, purulent secretions. Think to yourself again about that constellation of signs, infiltrate and fever, leukocytosis, purulent secretions. I don't think anybody in the wards at that moment is hesitating to treat that patient with broad-spectrum antibiotics. Yet when we look at the performance of that constellation relative to histology, what do we see? It drops the sensitivity down to below 20% and barely budges the positive predictive value. Now, what this analysis does not yet include is the microbiology. And you could very rightly be saying to yourself, this is an infectious disease, you should be looking at the microbiology should be diagnostic. So here are the data on the performance of BAL quantitative cultures relative to histology. And you can see this is data pulled from 5 or 6 different studies that the story is all over the place and not that different. So I would say the pooled sensitivity over here for a positive culture is probably around 60% or so. Positive predictive value pooled probably comes out to around 70%. In other words, not much more accurate compared to the clinical signs alone. Why is that? Well, you get the false positive diagnoses from contamination of your specimen from organisms inside the oropharynx or organisms colonizing the endotracheal tube. You get your false negatives either from prior exposure to antibiotics, which as you know is incredibly common in an ICU population, or from failure to sample the exact right segment of lung where the pneumonia might lie. In other words, if the pneumonia is in a left lower dependent area and you sample a left mid lung area, you will miss the pneumonia and get a false negative diagnosis from your quantitative culture. So the sad reality is that neither clinical signs nor microbiology is diagnostic for this condition. And as we think about the diagnosis and management of VAP then, this has enormous implications, the most important of which I think is humility. Now, given the lack of accuracy and specificity of the clinical signs, it's not going to surprise you that very reasonable, very thoughtful clinicians will disagree as to whether or not a given patient has pneumonia. That's true for frontline clinicians, it's true for infection control professionals trying to do hospital surveillance for VAP. Here's one analysis that reflects that. This was a study in which the investigators created 6 case vignettes of patients who may or may not have had pneumonia. They distributed them to hospital epidemiologists around the country and asked them to classify each case as pneumonia yes or pneumonia no. And you can see over here that equal number of respondents felt there was 1, 2, 3, 4, or 5 of the 6 patients who had pneumonia. In other words, there was no agreement whatsoever amongst these respondents as to whether or not pneumonia was present or not. So again, the implication is humility. It's clear that none of us knows with absolute certainty or accuracy who does or does not have this condition. And that has important implications then for how we pursue further diagnostics and how we manage these patients in terms of antibiotic initiations and antibiotic continuations. Now, a question you might be asking yourself is, would further imaging help? Thus far, we've only looked at portable chest x-rays. The example I showed you, while I'm sure very familiar to anybody who's worked in this setting, was not a very good quality study, right? It was a portable film, the patient was in a lousy position, it was underpenetrated, there were lots of overlying tubes and lines. And that's kind of the norm we're dealing with a critically ill population. So the question is, could we kick it up a notch and go to something like a CT? Would that give us a better capacity to work out who does or does not have this condition? Now, there are studies looking at this CT in intubated patients in particular, but I'm going to take a study to explore this issue from a non-intubated population because I think it's just a very nice study. And this was a study of pneumonia diagnosis in patients presenting to the emergency department. And the way this worked was that the patients presented to the emergency department, the emergency physician took a history, physical, reviewed the labs, reviewed the chest x-ray, and then made a determination in his or her head as to the probability that the patient had pneumonia. And all 319 patients in the study had suspected pneumonia, but in some cases it was enough evidence that the clinician felt it was a definite pneumonia. Another set of cases was probables, and some were possibles. What they did then is they took these exact same patients, and at the same time as they had their portable chest x-ray, they also went and got a CT scan. And then the clinicians was allowed to review the CT scan, or the study team reviewed the CT scan, to see how did that change their certainty around the diagnosis. And this is what happened. So you can see that amongst patients with a definite pneumonia, after CT scan, they still felt the majority of those patients definitely had pneumonia. By contrast, however, amongst those in whom the clinicians were more on the fence, they felt it was a probable pneumonia or a possible pneumonia, you can see over here that the CT led to a reversal of that decision in the majority of cases. Here's another way of presenting the same data. If you took those 319 patients with clinically suspected pneumonia and you sent them to CT scan, only about half made it into the definite or probable category. Or in other words, about half the patients with CT were excluded from further consideration. So that suggests that if you're on the fence about the diagnosis for a particular patient, a CT scan can help. Now, this can work in both ways. This study over here is emphasizing the possibility to rule out a diagnosis of pneumonia. It can happen in the opposite direction as well. So here's a very nice case study that was recently published from investigators in France. This was a patient whose portable chest x-ray, as you can see from the upper left-hand corner of the slide, looked pretty normal. Perhaps there was some obliteration of the left heavy diaphragm, but there was otherwise no obvious infiltrate. When they sent the same patient for CT scan, however, they were able to demonstrate dense bilateral lower lobe consolidations. So, again, suggesting that there's limited accuracy to a portable chest x-ray, and that getting a CT study can help in both directions with ruling in or ruling out, and it's most useful when you're on the fence about a diagnosis. Now, next question. After we've made our attempt to try to work out whether the patient has pneumonia or not, we have to, of course, decide whether or not to start antibiotics. And the question is, do we have to start antibiotics right away, or do we have the chance to allow a little time to pass to try to see if we can firm up our diagnostic confidence one way or another? And there's a steady stream of observational data that suggests that there might be a problem with delay in treatment. This echoes the literature inside the sepsis world, associating a delay in appropriate antibiotics to increase mortality. So here, amongst VAP-specific patients over here, comparison of patients who got adequate versus inadequate initial antibiotics, showing that those who got inadequate antibiotics in each of these four studies were associated with a higher rate of mortality. So can I go back? I'm going to go back to this one right here. Actually, you know what? Hold your thought.
Where were you on?
I'm going to pick it up on slide 20, but I just want to change the order of something here.
Were you on 21?
I was on 21, but I'm going to start now at 20.
These records. Let me start. They are. Like the laptop change for some reason. Tell me again, we were on 21, you're gonna go back to the top of 20?
Correct. So our next question is, do we have to start antibiotics right away? Do we have the luxury of a little bit of time to try to further evaluate the patient's condition and evolution to work out whether the patient does have pneumonia or not, or do we really have to start things right away? And just as in the sepsis literature, where there is an increasing number of observational studies suggesting that delay might be associated with increased mortality, there is parallel literature inside the VAP world. So for example, here are just two studies of many that are out there showing that a delay in time until therapy can be associated with an increase in mortality rates. There's analogous data showing that inadequate initial antibiotics increases mortality. So at first blush, these data would suggest we ought to be treating right away and aggressively with broad spectrum agents any patient whom there's a suspicion of VAP. Now, take into account that these are observational data and are associated then with potential risk of bias. A major bias is that the patients in whom we're most likely to use inadequate therapy are those patients who have resistant pathogens or unusual pathogens, and patients who have resistant pathogens are already the population that's likely to have a higher rate of bad outcomes. So these studies try as best they can to account for that potential source of bias, but again, as observational data, one always has to take it with a grain of salt. So these data would lean us towards starting early treatment with broad spectrum therapy. But we have to take into account as well that there is a risk towards over-treatment. And that is, first of all, we've established together that misdiagnosis is common. A third to a half of patients who are started on antibiotics for VAP probably do not have VAP. We have the ever-attendant risk of C. difficile, drug resistance, direct drug adverse effects, and of course there's cost. So there's real tension out there between early versus accurate treatment. On the one hand, there's the body of literature showing that delayed treatment increases mortality. At the same time, we have the body literature telling us that early treatment is often wrong and exposes patients to unnecessary risks, breeds C. diff and resistant bugs, and of course costs money. And you as a clinician are caught between this fundamental tension. The recommended compromise at this point for this imperfect situation is this: to start early, reevaluate frequently, and stop judiciously. And again, always be humble, accept the possibility that you might be wrong in either direction, having missed a VAP or overcalled a VAP. But this would say, don't second guess. If you think there's a VAP present, go ahead and start treating right away. But continue to reevaluate that patient. And if the patient's clinical evolution no longer fits with what you would expect for a pneumonia, then you should have the freedom to be able to stop treatment. In other words, if a patient looks like they have pneumonia, you start antibiotics right away, and 12 hours later or the next day the patient is rock stable, perfectly normal, the patient probably did not have pneumonia the day before. They probably had a mucus plug or they had a fluid issue or whatever the case may be, but it was probably not pneumonia because pneumonia doesn't get better that fast. Is there any risk associated with de-escalation? And again, this is another area where we have to rely upon observational data, which is by its nature imperfect. But the observational data suggests, at least in those patients in whom clinicians did decide to de-escalate, there was no apparent mortality signal. So over here is looking at a summary of hospital mortality rates in patients in whom clinicians did de-escalate, no change, or escalated the antibiotics. You can see that in the de-escalation set, mortality rates were on the lowest end. Again, it's imperfect data because it's observational, high risk of bias. Nonetheless, no signal of concern thus far. Now, what should we be treating with? And I think that question follows directly from what's the microbiology of VAP? What are the organisms associated with this condition? And what are their antibiotic resistance profiles? So here's the latest data from CDC. This is data pulled from 8,000 patients with VAPs. And you can see that over here that the number one player for VAP is Staph aureus, accounting for about a quarter of cases. And number two is Pseudomonas at around 20%. And then a slew of different gram-negatives account for the majority of the rest. So Staph aureus, again, is number one. Gram-negatives account for the balance. Pseudomonas is a prominent player. How about resistance rates? So here are the resistance rates from the same study. And you can see resistance is quite prevalent, quite widespread over here. Oxalin resistance rates approaching 50%, pseudomonal resistance rates approaching 30%, so on and so forth. Now, you can look at these data and say, oh my word, it's very concerning, and that compels the use of broad-spectrum therapy with anti-MRSA, anti-Pseudomonas, double gram-negative coverage, so on and so forth. But you can look at these same data, and we can find out if you're a glass half full, glass half empty kind of person, because you can take those exact same data and cut them in the opposite fashion and report them as susceptibility rates, and lo and behold, the picture looks much more promising, or much less dire. The other factor that I think has become apparent over the past 5 to 10 years is that it might be an oversimplification to take national surveillance data about resistance rates and assume that it applies in every location, in every hospital, in every location within a hospital. So for example, here are some studies on healthcare-associated pneumonia, looking at the prevalence of potentially drug-resistant organisms, that's MRSA, Pseudomonas, Acinetobacter, and gram-negatives, in a number of countries around the world. And what you can see over here is high variability, meaning that we probably can't make blanket statements about rates of drug resistance, but really one ought to know or to use the drug resistance rates that are particular to the location in which you practice, to your hospital, and even better, your ICU, because it can differ within a hospital and certainly between hospitals, and as we've seen over here, across between cities and across the world. And that was the prime message of the newest release of the guidelines from the Infectious Disease Society of America and the American Thoracic Society on the management of patients with HAP and VAP. Message number 1 was know your local antibiogram and distribution of VAP pathogens so that you can make a customized decision for your population as to what the most appropriate agent might be for treatment. Treat with an agent that will cover Staph aureus and Pseudomonas, because those are the most common pathogens. And conceptually, try to design a regimen that ought to be active against 90 to 95% of pneumonias. Now, that means, again, knowing your local distribution of pathogens and the local resistance rates for pathogens. And the guideline panel understood that sometimes it's difficult for people in many settings to be able to get those data. Not every hospital creates an antibiogram. Not every hospital has the numbers or the IT capacity to generate ICU-specific antibiograms. And so these are some rules of thumb that they gave if you aren't able to work out your local exact distribution of pathogens and resistance patterns. Include MRSA coverage if the local prevalence of MRSA overall, not just VAP, is greater than 20%. If there are risk factors for MDR pathogens, mechanical ventilation, or septic shock. And then use 2 anti-pseudomonal agents if greater than 10% of gram-negatives are resistant against whichever agent you're being considering for monotherapy, or risk factors for MDR pathogens or septic shock. And again, these are from the 2016 version of the guidelines. So, that being said, what should one treat with? And again, I think you need to take into account 2 factors over here. One is the susceptibility to the proposed agent and the organism frequency. So I've gone through the exercise for data from my own hospital, but as I've been trying to convey, it's important for you to do the same exercise for your hospital. So taking together all our VAPs and then working out what kind of pathogens cause them and what their antibiotic resistant profiles are, this is what I see in our data over here, that if I were to use any of these agents listed on the screen in isolation, this is the percentage of VAPs that I would likely be successful in covering. So in isolation, oxacilin's only going to cover about 20%, vancomycin around 26%, so on and so forth, and ceftazine, cefepime, etc., around 75%. So not very good, and it would appear that in my hospital setting, it's not adequate to use monotherapy with any one of these agents because I'll be missing at least a quarter of the population. However, if you go ahead and you combine these gram-negatives with a anti-MRSA drug, for my population, you do actually get up to that 90% threshold, which we think is sort of the minimum when choosing an empiric regimen. So at my hospital, you can use vancomycin or linezolid, and ceftazidime or cefepime, america, and penem for empiric therapy. But again, I cannot emphasize the importance of doing this exercise for your hospital, because what's true in my place might not be true in your place. So the take-home for empiric treatment should include something for MRSA, and that can be either vancomycin or linezolid. Those two agents are associated with similar clinical outcomes, particularly mortality rates, and something for gram-negatives, including Pseudomonas. Again, in my hospital, it's ceftaz, cefepime, or meropenem, but in your hospital it might be different. Add a second anti-Pseudomonal agent if you have a higher local probability of Pseudomonas resistance, known colonization with resistant pathogens inside your particular patient. You know they've had a resistant pathogen in the past. The patient has septic shock, ARDS, prolonged hospitalization, or acute renal replacement therapy. Now, do we need to go ahead and get cultures? Should we be getting endotracheal aspirates or BALs? And the answer to that is absolutely. What I think I've tried to convey to you is that having culture data to guide you is absolutely essential. And the major benefits are, first of all, a positive culture will allow you to tailor your therapy so you can choose the exact one drug that might be appropriate for your patient. Negative cultures may facilitate stopping antibiotics early, presuming the patient is doing well. And from a hospital management or ecology, epidemiology point of view, cultures are essential to help us track pathogen frequency and resistance rates so we can work out, moving forward, what the appropriate empiric regimens might be for any given setting. Does it matter if you use invasive cultures, meaning BAL, versus non-invasive cultures, which are endotracheal aspirates? There are 5 randomized controlled trials looking at this question. Here's a meta-analysis showing the combined impact on mortality. And as you can see over here, no difference in mortality using invasive versus non-invasive. So our practice is to default to endotracheal aspirates for a VAP diagnosis and to reserve BAL for situations in which therapy is failing on a endotracheal aspirate guided strategy, or there are other compelling reasons to do the BAL. How long should we be treating for? Now, the classic answer to this question comes from a beautiful study done back in about 15 years ago. And this was the famous study by Jean Chocht and colleagues from Paris comparing 8 versus 15 days of antibiotic therapy for ventilator-associated pneumonia. And what they did in the study was a double-blinded, randomized trial in 51 French ICUs with about 400 patients. They randomized patients to 8 days versus 15 days of therapy. And as you can see over here, there was no difference in all-cause mortality, ventilator-free days, organ failure-free days, or ICU length of stay. Hence the recommendation that our default treatment duration for VAP should be 8 days or 7 days. Now, as you've probably remember, there was one signal of concern inside this study, and that was with regard to recurrent pulmonary infections. And what they saw was that with non-fermenting gram-negatives, that's things like Pseudomonas, Acinetobacter, there was a higher rate of recurrent pulmonary infections. And I think from that observation led to a routine practice to give 14 or 15 days of therapy for patients with Pseudomonas infections in particular. But I would venture to say that if we look more closely at the details of the study, maybe that potential signal of concern was exaggerated. And the reason for this is as follows: that if you look below the hood of this really fantastic study, their definition for recurrent pneumonia was microbiological, meaning that so long as the patient had a repeat bronchoscopy with a positive quantitative BAL culture, that was defined as a recurrent pneumonia. But as we saw together, a positive culture alone is not a perfect predictor of the presence or the absence of a pneumonia. Remember here are the slides showing that the net sensitivity for a positive BAL culture is around 60%, and the positive predictive value is around 70%. So when they said that a patient had a recurrent infection, what they really, I think, were saying was the patient had a persistent positive pulmonary culture. And that's not the same necessarily as a patient having clinical infection. I think it's very informative if you look within that study to not the rates of persistent microbiological cultures for that population treated with short course therapy versus long course therapy, but rather to look at the clinical outcomes in that subset of patients with non-fermenting gram-negatives, with Pseudomonas, Acinetobacter, etc. So here are the clinical outcomes in patients from this study with non-fermenting gram-negative bacilli, and lo and behold, when you look at the clinical outcomes over here, no difference in all-cause mortality. In fact, it was numerically lower in the short-course group. No difference in ventilator-free days, no difference in organ failure-free days, no difference in ICU length of stay. So from a clinical point of view, in fact, it appeared that there was no downside, no detriment associated with short-course therapy, even for Pseudomonas, Acinetobacter, and other gram-negative rods. So I think the default recommendation in the new 2016 guidelines is 7 days of therapy regardless of the pathogen type. Now, of course, you'll moderate this with your clinical judgment. You won't apply this in a blind cookbook kind of a fashion, but you'll evaluate how the patient is doing. Of course, the patient is doing well, absolutely, you'll stop at 7 days. If the patient is doing poorly, you won't stop willy-nilly, but in fact, you'll ask yourself the question, why is the patient doing poorly? And I would argue probably the next step is not just simply just continue the antibiotics, but further diagnostic evaluations. That could be another CT scan, that could be additional BAL, whatever the case may be. But obviously, I'm just these recommendations for duration of therapy are contingent upon the patient's clinical course. Okay, so very nice. I think that tells us that 7 or 8 days is adequate. Could we go below that? Now, there is a nice evolving literature on using shorter courses of therapy for patients with suspected ventilator-associated pneumonia. Here are some of the earlier studies looking at the possibility of earlier discontinuation. The first study was 81 patients randomized to standard therapy versus discontinuation if the clinical signs had normalized at 3 days, and they found no difference in ICU length of stay or mortality, suggesting that short course therapy in a patient whose clinical signs had normalized was fine. Another study showing a similar sort of outcome over here, 290 patients randomized to standard therapy versus early discontinuation if an alternative diagnosis or resolution of clinical signs. Antibiotics were stopped a little bit early in 89% of the intervention group, and again, no difference in ICU length of stay, duration of ventilation, or mortality. So it appears that once a patient's clinical signs have normalized, it would appear from this literature, nascent as it is, that it is safe to stop antibiotics. Now, there has been a good and growing literature on the use of aids to help us with that decision beyond simply our clinical evaluation alone. One approach has been to use procalcitonin surveillance. And again, remember that procalcitonin can be used for many different things, to prognosticate, to inform the decision on whether to start antibiotics or not, or to help with our question right now, which is when we can stop antibiotics. I'm just going to focus on that third question alone, antibiotic discontinuation. I'm not going to comment upon the other potential indications for procalcitonin because they're a conversation unto themselves. But over here, this is the latest and greatest study in the ICU setting of the use of procalcitonin surveillance to inform antibiotic discontinuations. And this was 621 critically ill patients. It was an open-label study from eight ICUs in France. Sorry, I have to go back. Apologies. I'll take from here.
And you're going to go back.
I'm going to just restart the slide.
Restart slide 52. Okay.
Yeah, give me a second.
And I'm going to pull your mic on.
Oh, sorry, yeah.
Okay.
So one of the strategies that's been proposed to help with informing the decision on when to discontinue antibiotics is procalcitonin. Now remember, there are three potential ways that procalcitonin can be used. One is to prognosticate, one is to help with the decision on whether to start antibiotics or not. The third is to help with when it's safe to stop antibiotics. We're going to be commenting only upon that third issue, the issue of using procalcitonin to inform antibiotic discontinuations. The other two topics are worthy of sort of discussion unto themselves. But on the issue of using serial procalcitonin surveillance to inform when it might be safe to stop antibiotics, two key ICU studies I'd like to share with you. One was a pro rata study done in France, 621 critically ill patients, and randomized patients to daily procalcitonin levels compared to usual care. And when the procalcitonin level dropped below a certain threshold, clinicians were advised that they should consider stopping antibiotics. And with that strategy, they were able to show an increase in antibiotic-free days. So we here the procalcitonin arm is in red, control arm is in orange, and you can see in the procalcitonin arm they were able to shave about 3 days of antibiotics off treatment for those patients. And that did not appear to be associated with any kind of adverse outcome, so no difference in ventilator-free days, ICU length of stay, or mortality, suggesting that the strategy was safe. And then more recently, a similar study, the SAP study, done in the Netherlands with about 1,500 or so critically ill patients, similar sort of design to the pro rata study. This was done in 15 ICUs. And again, they were using a strategy of daily procalcitonin surveillance, were able to show a decrease in median duration of antibiotics without any apparent signal of concern for ICU length of stay or mortality. And very nicely within this study, they reported on the outcomes in particular for the VAP subgroup. And over here, look at this. Median duration of treatment for the procalcitonin arm was a mere 4 days with an interquartile range of 2 to 7 versus 7 days in the control arm. Again, suggesting that less than 8 days of therapy very well may be possible for patients with VAP. So that's a potential strategy to consider if you want to further decrease your duration of antibiosis. And then the third strategy in terms of an approach to decreasing duration of antibiotics was just published recently. This was looking at the patient's ventilator setting as a potential clue as to when it might be possible to stop antibiotics. And the thinking behind this study was as follows. Severe pneumonia typically impairs gas exchange, and a severe VAP therefore ought to be associated with higher levels of ventilator support, a requirement to increase the PEEP or the FiO2 or whatever the case may be. So these investigators reasoned that if a patient has stable and minimal ventilator settings, meaning a PEEP of less than 5 and an FiO2 of less than or equal to 40, despite the pneumonia, perhaps that's an indication that the pneumonia is mild or that the patient doesn't have pneumonia at all. Begging the question, can one look at serial ventilator settings to identify potential candidates for shorter courses of antibiotics? In other words, if the patient's ventilator settings are minimal and rock stable, despite the purported ventilator-associated pneumonia, then maybe you can get by with a much shorter course of treatment compared to what you might otherwise have done. So this was a retrospective propensity matched analysis in one hospital, looked at 30,000 patients on mechanical ventilation, of whom about 84.4% were being treated for VAP. And about half of that VAP population, interestingly enough, fell into this category of minimal and stable ventilator settings. The 514 patients were propensity matched, 257 treated with less than 3 days of antibiotics, 257 treated with more than 3 days of antibiotics, and were well matched with regard to a number of potential confounders. And what they found was no difference over here in clinical outcomes, so no difference in days to extubation, days to hospital discharge, or hospital death, suggesting that those short course treatments in this subset of VAP patients with minimal and stable settings did not appear to be problematic. In other words, short course treatment of 1, 2, 3 days was fine for that population. So those three different approaches to get yourself below 7 or 8 days of treatment: clinical judgment alone, procalcitonin, or evaluation of daily ventilator settings to find those who have minimal and stable settings. Let's switch gears a little bit and talk a little bit about prevention over here. How can we prevent ventilator-associated pneumonia? Now, the classic approach to this is the ventilator bundle, which has the following 6 components. Elevate the head of the bed, daily sedative interruptions, daily assessment of readiness to wean, stress ulcer prophylaxis, DVT prophylaxis, and oral care of chlorhexidine. This is the bundle that was promulgated in the 100,000 Lives campaign of the Institute of Healthcare Improvement, the 5 Million Lives campaign. I dare say that this is common practice in just about every ICU in the United States. And at first blush, it appears that this has been a very successful strategy. So if you look at national VAP rates for the United States, they appear to have taken a real nosedive over time. But as we alluded to in the beginning of this talk, the diagnosis of VAP is real bare. A lot of the signs are non-specific, they're very subjective, and when people have looked at this national surveillance data, there's always been the worry, is the decrease in VAP rates due to a true decrease in disease or due to people being stricter over time with their application of those subjective and soft clinical definitions? And there was a study that just came out a few months ago suggesting that maybe the latter is true. This was an analysis of US government audits of patients being reported to CMS under various programs to look for the presence of pneumonia. And under this analysis, at least, it appeared that VAP rates over the past decade have in fact been stable, have not changed, suggesting that maybe that bundle, which we think has been so successful, maybe has not been quite so impactful as we would have hoped. And indeed, if you kind of dig below the surface of the components of that bundle and look at each bundle component piece by piece, you'll find that some are more potent and others less so. So for example, here's the data on the association between head-to-bed elevation, the first component of that bundle, and VAP rates. Turns out there's actually a real paucity of randomized controlled trials on this particular question. There was one very positive study with 86 patients that was published almost 20 years ago now. However, a subsequent study, much larger, did not show a decrease in VAP rates with elevation head of the bed. And the third study only had 30 patients, so it really was underpowered to tell us much of anything. So it turns out this core recommendation is supported by very little evidence. Now, I'm not saying it doesn't work and it's not helpful. There are other compelling data from an observational point of view and from a pathophysiological point of view that suggests that this might be useful. But I think it's important to know that the underpinnings for our classic ventilator bundle are in fact quite weak. The same is true of some other components of the bundle. Here's some of the data on stress ulcer prophylaxis. So the emerging data on stress ulcer prophylaxis suggests it probably increases the risk for pneumonia. Here's 3 studies that appear to give that signal. One was from a cohort study of 64,000 admissions to the Beth Israel Hospital in Boston, and amongst patients who had received acid suppressants, they had a 1.3 times greater odds of hospital-acquired pneumonia. A similar finding in a case control study of cardiothoracic surgery patients treated with pantoprazole versus ranitidine. Those who got pantoprazole were more likely to get hospital-acquired pneumonia than those on ranitidine. And more recently, a nice propensity match analysis of 31,000 patients with severe sepsis, and patients who received stress ulcer prophylaxis were about 20% more likely to develop hospital-acquired pneumonia. So this bundle component really seems to be associated with harm. Oral chlorhexidine, and then again another key component of the bundle. Our use of oral chlorhexidine is predicated upon a couple of meta-analyses that suggested that collectively the randomized controlled trials are associated with a decrease in VAP rates. Now, if you look at this meta-analysis, you'll see that individually the vast majority of studies did not find an association between chlorhexidine and lower VAP rates. The signal really comes from meta-analysis alone. But those same meta-analyses actually also showed a point of concern. Check this out. Here's a meta-analysis looking at mortality as the outcome, and these investigators are suggesting that chlorhexidine is associated with a higher risk of mortality. So again, if we look at our classic VAP bundle, those are 3 components in whom we have either a paucity of evidence or even possibility of harm. And if you couple that with our observation that our impression that VAP rates have dropped over the past decade might not be true, you might start to scratch your head and say, gee, is VAP really the best way to monitor and inspire better care for ventilated patients? It seems like there's a number of issues. It's A, not a reliable outcome, and B, has maybe led us down the garden road in terms of choosing the right interventions to prevent this condition. So it was those sorts of observations that catalyzed CDC in partnership with the critical care societies to come up with a new approach to quality surveillance for ventilated patients. And this was the framework of ventilator-associated events, which is the current recommended surveillance target per CDC. And this is an alternative approach to surveillance. The thinking behind this particular ventilator-associated events is to say that, gee, if at the end of the day we can't tell with certainty who does or does not have pneumonia, maybe we shouldn't be focusing our surveillance on pneumonia. Let's look more broadly for the syndrome of complications in general in ventilated patients. And this has a couple of advantages. Number one, it's a more accurate description of what we can and cannot tell using surveillance definitions. They really are not good at saying who does or does not have pneumonia. But if we focus our surveillance on the syndrome of complications in general rather than pneumonia in particular, it also has the implication that we ought to be channeling our prevention efforts to preventing all complications of mechanical ventilation, not just pneumonia. Why do we only care about pneumonia alone? What about ARDS, pulmonary edema, atelectasis, all the other things that can go wrong in a ventilated patient? In addition, once we say that we're no longer going to be focusing surveillance on pneumonia alone, it allows us to simplify the surveillance definition, because we don't have to find pneumonia. really all we have to find is deterioration on a ventilator. And that in turn allows for the possibility of automated surveillance. So the challenge we're trying to address over here, as we said, partly is surveillance efficiency and accuracy, but also the fact of recognizing that VAP itself is but the tip of the iceberg. There are a range of other important conditions associated with bad outcomes for mechanically ventilated patients that we ought to be tracking as well. And VAE is designed to try to identify that broader bundle of complications. Here, in essence, is the way that it works. A ventilator-associated event is defined as a sustained rise in the daily minimum PEEP of 3 or more centimeters, or the FiO2 of greater than 20 points, after a period of stable or improving daily minimum PEEP or FiO2. And so what you do in practice is you lay out the patient's daily minimum PEEP and FiO2, 1 line per calendar day. And if you scan your eye down this list, what you'll see over here is that this patient had stable ventilator settings for a number of days and then suddenly had a jump, and this patient therefore meets the criteria for VAE. There are sub-criteria to try to identify those which might be infection-related and those which might be pneumonias. But the core condition over here is a VAE or a VAC, a ventilator-associated event, which again is simply conceptually deterioration of ventilator, not otherwise specified. Now, there's an exploding body of literature on this new entity. Here's a partial snapshot of some of these studies on outcomes for patients. And the consistent message from the literature appears to be that a VAE is a bad thing to have. It's associated with an increase in mortality as well as length of stay and duration of mechanical ventilation. Here's just 6 of many studies that are out there showing the association that a VAE is associated with about a doubling of the risk of dying compared to a similar patient without a VAE. Some of these studies included classical VAP definitions as well, and in most cases, a VAE was a more morbid condition compared to a VAP. The other study, the message that's been emerging from the literature has been that while the rate of VAEs is the same or a little bit lower compared to VAP, the overlap between VAE and classically defined VAP is really quite small, meaning the majority of patients with VAEs do not have VAP, and conversely, there are many VAPs that do not meet VAE criteria. So a take-home message, I think, for today is that a VAE and a VAP are not the same thing, and therefore, as we move towards thinking about prevention, we can't just blindly apply the old VAP bundle, all the more so given the weaknesses in the VAP bundle that we explored together. So this begs the question then, well, if a VAE is not a VAP, what is it? What actually clinically is happening to that patient to trigger the rise in ventilator settings that leads to a VAE? And again, there are a number of studies on this question, and most of these studies are case series looking at patients with VAEs and then analyzing to see what was the clinical precipitant that led the clinical team to increase ventilator settings. And the messages just seem to be pretty consistent across these studies. The majority of conditions that cause a VAEs is pneumonia, excess fluids, atelectasis, and ARDS, and that accounts for the majority in just about all the studies that have done this kind of analysis. So in summary, a VAE is a VAP or fluids or ARDS or atelectasis in the majority of cases. So if we want to get ourselves to decrease VAE rates, how are we going to get there? And I'd say conceptually the approach is as follows. There's 2 major pathways to preventing a VAE. Number one is get the patient off the ventilator, right? If the patient's not on the ventilator, they're not going to have a ventilator-associated event. So think towards the kinds of interventions that have been shown to decrease duration of mechanical ventilation. The other conceptual approach is to target those 4 primary conditions that we saw were responsible for most VAEs: pneumonia, atelectasis, ARDS, and excess fluids. And I think if you look at the literature, you'll find that in fact the things that lead to lower duration of mechanical ventilation and the things that target the primary conditions associated with VAEs are very often one and the same thing. So my take on the literature is that the key things that hit both of these targets are as follows: minimize sedation, paired SATs and SBTs, so spontaneous awakening trials and spontaneous breathing trials, early mobilization programs, low tidal volume ventilation, conservative fluid management, and minimization of blood transfusions. Now, this list of interventions, I think, should be totally non-controversial. This mirrors well the ABCDEF bundle and other emerging best practices in critical care. So what we're seeing over here, which is very lovely, is a coming together of CDC's new surveillance metric, VAE, and emerging best practices in critical care. It would appear that there's a decent likelihood that these best practices are actually ideally targeted towards reducing VAEs. Okay, let's summarize what we've been through today. Diagnosing pneumonia is very challenging. We're often wrong, and CT may help. Know your local antibiogram and distribution of VAP pathogens in order to inform empiric treatments in your setting. Aim for an empiric regimen that will be active for at least 90 to 95% of patients, and that will likely then need to include at least one agent active against MRSA, and that could be linezolid or vancomycin, and one or two agents active against Pseudomonas. Less may be suitable depending on your local distribution of pathogens and resistance. So in other words, if you have a very low rate of MRSA and you have pan-susceptible Pseudomonas in your particular practice setting, you might be able to get by with monotherapy. Get cultures in order to help you know your local ecology of pathogens and resistance. 7 to 8 days of treatment is usually adequate for all pathogens. Shorter courses may be adequate for some patients. Procalcitonin, clinical judgment, or analysis of ventilator settings may help to identify candidates for shorter courses. CDC created ventilator-associated events in order to enhance objectivity, facilitate automation, and expand prevention efforts for ventilated patients. And VAEs are typically caused by pneumonia, ARDS, atelectasis, or pulmonary edema. And thus, best practices to prevent VAEs probably include minimizing sedation, spontaneous awakening and breathing trials, early mobilization, low tidal volume ventilation, and conservative fluid management. Thank you. Let me go over now to our review questions. A 76-year-old diabetic woman with a history of congestive heart failure is admitted to a surgical ICU on a ventilator following a motor vehicle accident. She was the unrestrained driver of the car. She suffered multiple fractures of her ribs and right femur. She is emergently taken to the OR for open reduction and internal fixation of a femur fracture. 2 days later, she develops fever, tachypnea, increased oxygen requirement. The nurse reports increased secretions from the endotracheal tube. Lung sounds are obscured by the ventilator. She has moderate anasarca. White count is 17. A portable chest X-ray shows bilateral low lobe opacities. You take cultures of blood, urine, and endotracheal tube aspirates. You administer furosemide and begin empiric treatment for possible ventilator-associated pneumonia with vancomycin and cefepime. Here's the question. 1 day later, the patient is improving. Her fever persists, but her white blood cell count is normalized, and she requires minimal support from the ventilator. Her chest X-ray still shows some opacities in the lower lobes, but they're less pronounced. All cultures are negative thus far. At this point, what would you do? Continue vancomycin and cefepime for 8 days, switch vancomycin to linezolid, continue cefepime, de-escalate to cefepime alone, switch to ciprofloxacin alone, stop all antibiotics. And my best answer was stop all antibiotics. I would say the patient's rapid improvement argues against a true pneumonia. The majority of patients with the constellation of signs for VAP do not have pneumonia on histology. In this patient's case, her fever could be post-op, her infiltrates due to pulmonary contusion, pulmonary edema, atelectasis. Stop all antibiotics to minimize the risk of selecting for resistant pathogens. Question 2. A 67-year-old man with a history of cholangiocarcinoma is admitted to hospital with fever, confusion, and hypotension. Labs are notable for leukocytosis, thrombocytopenia, and an elevated bilirubin. Imaging is notable for biliary dilatation. He is emergently intubated and treated with antibiotics, fluids, and vasopressors. He undergoes emergent ERCP with placement of a biliary stent. He improves over the next 2 days, but then develops recurrent fevers, increased secretions from the endotracheal tube, and worsening oxygenation. A chest X-ray suggests a new left lower lobe infiltrate and an endotracheal tube aspirate is positive for Pseudomonas aeruginosa. How long will you treat for? 3 days, 5 days, 7 days, 14 days, 21 days? My answer, 7 days. I say that because even though the patient has Pseudomonas, that clinical outcomes in patients treated with 7 to 8 days of antibiotics are similar to those treated with 14 to 15 days, even with Pseudomonas, and shorter course therapy is therefore preferred. Again, our old caveat, ultimate duration of treatment should be tailored to each patient's clinical response, and that could include shortening or extending the treatment from the 7-day default.